Blood and tissue helminths. A Trichinella spiralis infection begins when a person ingests undercooked meat, commonly pork or wild game, containing encrusted larvae. Once the meat reaches the stomach and small intestine, digestive enzymes release the larvae, which then penetrate the duodenal and jejunal mucosa. Within about 2 days, the larvae mature into adult male and female worms. After mating, the fertilized females burrow into the intestinal wall, where they release thousands of newborn larvae. These newborn larvae enter the bloodstream and are transported to various tissues, primarily the heart and lungs, but they develop into the infective stage only when they reach the striated muscle. In the muscle tissue, the larva undergoes several molts and curl into a characteristic spiral shape, forming cysts that can remain viable for years. So after about 30 days, the immune response by the host will have a reaction that surrounds the larvae, and the capsule forms a cyst. That's then ingested by a new host, or it dies and becomes calcified within the cyst. We see this in Eastern European countries, Russia, Spain, Chile, Mexico, and the United States. Pathology can be asymptomatic to basically a full fulminating fatal disease, but the usual presentation is going to be a mild febrile illness. So we think back to the life cycle on the previous slide, and there are 3 phases. You have the intestinal phase, the extra-intestinal, and muscle invasion, as well as convalescent. The intestinal phase of Trichinella spiralis infection presents as a nonspecific gastroenteritis with symptoms such as diarrhea, abdominal pain, and nausea. During the extra-intestinal and muscle invasion phase, patients commonly experience fever, headache, acute paraorbital edema, and muscle pain caused by larval migration and inflammation. The convalescent phase may involve more serious complications due to granulomatous reactions and hemorrhagic myocarditis affecting the cardiac, pulmonary, and neurological symptoms. These complications contribute to a fatality rate of approximately 2% in severe cases. So for laboratory diagnosis, we are not looking for adult and larval stages in a stool culture. We are actually will either do serology or stains on a muscle biopsy. So the CDC definition for Trichinella positive is Trichinella is positive muscle biopsy or serologic test, with the patient also demonstrating eosinophilia, fever, myalgia, or paraorbital edema. Serology, your most common is the bentonite flocculation test or ELISA. And again, definitive diagnosis is based on recovery of the viable larva from a muscle tissue. Echinococcus granulosus has a complex life cycle involving definitive and intermediate host, with humans serving as accidental host. The definitive hosts are primarily carnivores such as dogs, wolves, and cats, which harbor the adult tapeworms in their intestines and release eggs into the environment via their feces. The intermediate hosts are usually herbivores like sheep and cattle, which ingest the eggs while grazing. Inside these hosts, the eggs develop into larval cysts in organs such as the liver and lungs. Humans become infected accidentally by ingesting the eggs, often through close contact with infected dogs or contaminated food and water, which can lead to the development of the cystic disease. Echinococcus granulosus is a small tapeworm measuring only 3 to 6 millimeters in length. Its scolex features 4 round suckers and 2 rows of hooks, which help it attach to the host intestinal lining. The worm's body is composed of just 3 proglottids, immature, mature, and gravid. The gravid proglottid ruptures to release eggs, which resemble those of Taenia species. After ingestion by an intermediate host, the egg hatches in the small intestine, releasing an oncosphere that penetrates the intestinal wall. It is then carried via the bloodstream to internal organs, particularly the liver and lungs, where it there develops into the characteristic hydatid cyst. This cyst has a thick, laminated outer layer and a fluid-filled interior, providing protection for the developing larva. As Echinococcus granulosus cysts mature, brood capsules and daughter cysts inside the main cyst may rupture, releasing numerous scolices, the infective larval stage. These scolices accumulate as hydatid sand, a granular material that can be aspirated from cysts and examined microscopically in the laboratory for diagnostic confirmation. Echinococcus granulosus infection is prevalent among sheep herders and livestock handlers in regions such as Australia, New Zealand, Argentina, Uruguay, Spain, and the Middle East. In the United States, cases are most commonly reported in Arizona, New Mexico, and Utah. The parasite is also more common in temperate and subarctic regions, affecting indigenous populations such as the Eskimos and Native Americans of Alaska and Canada. The clinical symptoms of Echinococcus granulosis infection largely depend on the location of the hiated cyst and the extent of its growth and resultant tissue damage. Early in the infection, the host mounts a mononuclear cellular response aimed at killing the oncosphere as it invades tissues. However, most patients remain asymptomatic for long periods until the cyst enlarged sufficiently to cause pressure necrosis, compress surrounding tissues, and impair the function of affected organs such as the liver or lungs. Diagnosis is often incidental, made during a chest or abdominal x-ray performed for unrelated reasons, revealing cystic lesions. Serologic tests, especially ELISA, can support the diagnosis of detecting antibodies against the Echinococcus antigens. There are three main species of schistoma that cause human infections. So we have Schistoma japonicum, Hematobium, and Mansoni. Their life cycle differs from other trematodes in several key aspects. Infection occurs through the penetration of the skin by infective Cerciae, which are free-swimming larval forms released by the snails. Unlike many other trematodes, adult schistoma worms are dioecious, meaning they exist as distinct male and female worms rather than being hermaphroditic. Additionally, their eggs are not operculated, which is a feature that distinguishes them from many other flukes. Schistoma species have a single intermediate host, a specific freshwater snail, where larval development takes place before Cerciae are released into the water. Infection begins when Cercariae are released from infected freshwater snails and penetrate the human skin during contact with contaminated water. Upon skin penetration, the Cercariae shed their tails and enter the bloodstream, traveling through the capillaries to reach the portal circulation in the liver. This is where they mature into adult worms. After maturation, the adult worms migrate in their preferred sites depending on the species. So, Schistoma japonicum typically migrates to the veins of the small intestine, where Schistoma mansoni goes to the veins of the large intestine, and Schistoma hematobium goes to the veins of the urinary bladder. These locations are critical to the clinical manifestations and pathology associated with each species. After fertilization, female schistoma worms release numerous eggs into the bloodstream. These eggs possess proteolytic enzymes and often a spine, which are species dependent, which aid in penetrating the walls of blood vessels and surrounding tissues to reach the intestinal or bladder lumen. Once the eggs enter the intestine or bladder, they are expelled with the host feces or urine into fresh water. In the fresh water, the embryonic eggs hatch, releasing a free-swimming larval form called the miracidium. The miracidium actively searches for a suitable freshwater snail, which is the intermediate host, into which it penetrates. Inside the snail, the parasite undergoes several developmental stages before emerging as infective Cercariae, thus completing the life cycle and ready to infect a new human host. Schistoma mansoni is primarily found in South America, Africa, and the Caribbean islands. Schistoma japonicum is endemic to Asia, while Schistoma hematobium is prevalent in Africa and the Nile Valley. Notably, none of these species occur naturally in North America. The pathology of schistiomasis progresses through three stages. The initial stage often presents as dermatitis at the site of the cercarial penetration. This is followed by a hepatitis syndrome, which is characterized by liver inflammation. A serum sickness-like syndrome may develop, featuring symptoms such as eosinophilia, fever, abdominal pain, and diarrhea. Chronic infection leads to extensive hyperplasia, leukocyte infiltration, and fibrosis at sites where eggs are deposited, which can cause significant tissue damage and organ dysfunction. With the laboratory diagnosis, recovery of the eggs in feces, urine, or a biopsy. So think about, again, where the eggs mature and how they're excreted. Schistoma japonica and mansoni would be your fecal specimen or a rectal biopsy, where Schistoma hematobium, because they burrow through the bladder wall and can be recovered in a urine specimen. Oftentimes we will do a sedimentation concentration. If that's negative, then they may follow up with a muscle biopsy and serology. With the urine, the maximum of eggs in a urine recovery typically occurs between 10 a.m. and 2 p.m. And all of these species are embryonated and do lack operculum. On the parasitology tutor, there are different in sizes, but what actually separates this species is the location of their spine. So Japanicum is the smallest of all of these, and it is indicated by a lateral spine. So you can kind of see on the picture above there what I'm talking about here. And if you're doing a wet mount, sometimes if you tap the slide, the parasite will roll. And since you're not always going to see that tiny lateral spine, it's kind of like you almost need to turn them over to be able to actually see it and identify it. Mansoni has a thorn-shaped lateral spine, and Hematobium has a prominent spine at one end of the egg. Diagnosis can be either serologic diagnosis with ELISA and immunoblot techniques, or the other identification procedure may be an ultrasound of the liver or the bladder.